Okay, so basically, what we are going to do today is to discuss about management of chronic kidney disease. So I'm not going to talk to you a lot about what chronic kidney disease is. It is a kind of you should have already had lectures on that. So basically, I'll be touching on the management and mainly on the therapeutic aspects of managing chronic kidney disease. So, so you know what chronic kidney disease is? It is abnormal kidney function or kidney damage persisting for more than 3 months. So basically, either you should have abnormal kidney function or damage, and it has to last for more than 3 months. So that is what chronic kidney disease is. And this is the standard classification of staging of CKD, which you're already familiar with. So there are 5 stages. Stage 3 is divided into 3A and 3B. So this is based on the estimated GFR. So I won't be spending a lot on this. So, and you need to know the causes of CKD. So commonly it's due to either diabetes or hypertension. In addition, there could be other causes. So we will not spend a lot of time on that. So now moving on to the management. So basically, managing CKD, there are few components that you need to keep in mind. First thing is, now you know, I told you the causes of CKD. So basically, if there are treatable causes or reversible causes, then you have to correct them. So that's the first step in the management. Then the next thing is, if we can't reverse the cause, then the next thing is, if we need to prevent the disease progression. So we need to try to do certain things to minimize the progression of the disease. Next thing is, CKD is associated with a lot of complications. We will discuss them later, and we need to manage the complications. And then in addition to CKD, a lot of patients have other comorbidities, so they may be on various drugs, and we need to adjust the drug doses based on the eGFR. So that is the next, another important component. Then if we fail in our efforts to delay the progression, then we might have to end up providing renal replacement therapy. So we need to know something about renal replacement therapy also. And finally, chronic kidney disease itself is an independent risk factor for CKD, for cardiovascular disease, and a lot of comorbidities associated with CKD are also risk factors for cardiovascular disease. So prevention of cardiovascular disease is also important component. So these are the 6 main components in management of CKD. So we'll take one by one. So treating reversible causes. So sometimes you can have, like, diabetes, hypertension. Those are the things that usually cause CKD. So you might have to treat them. In addition to that, sometimes you can have additional acute insults on top of CKD. So this is called AKI on CKD. This is due to infections, various drugs. Sometimes you can have urinary tract obstruction, sometimes reduced renal perfusion. So, all these risk factors can lead to acute kidney injury. Can you all mute your mics, please? Some of them I think still on. Right. Okay. So, so this is treatment of underlying causes, risk factors. Then prevention of disease progression. So, so as I told you, diabetes is one of the commonest cause of CKD. So you can treat the primary disease. If it's diabetes, you treat the diabetes. If it's glomerulonephritis, you can treat the glomerulonephritis, and hypertension, you treat hypertension. In addition, any CKD patient, it can be associated with high blood pressure, or the cause could be high blood pressure. So you need to optimize the blood pressure control. Then if the CKD is associated with proteinuria, you can use drugs which can reduce proteinuria. So these are classically the inhibitors of renin, angiotensin, aldosterone system. So commonly what we use is ACE inhibitors or angiotensin receptor blockers, but there are other types of RAS blockers such as aldosterone antagonists or direct renin inhibitors. So you will have to be familiar with them. So then protein restriction is also one of the things that you can do to prevent disease progression, because excessive proteins is associated with increase in GFR. So if you reduce the protein intake, GFR can reduce, and why it helps the protection of kidney functions when you have increased GFR and hyperfiltration secondary to increased protein consumption, then there can be a hyperfiltration injury to the kidney, and that can um, speed up the progression of kidney disease. Then smoking cessation is another important thing you need to advise these patients, because that also has an independent effect on renal progression. And also there is some evidence that treatment of chronic metabolic acidosis in CKD can be useful in delaying progression. So these are some of the things that you can do to delay the disease progression. So the next important thing is treating complications. So as you know, CKD is a multi-system disorder which can affect almost all the organs in the body. And commonly, this is associated with these complications. That doesn't mean that these are the only complications you get in CKD. So you can get anemia, you can get bone mineral disorder, you can have volume overload, metabolic acidosis, electrolyte abnormalities such as hyperkalemia, hyperlipidemia, and also sexual dysfunction. So we'll take one by one. So treating anemia, this is one of the most important components in treating CKD. And it's predominantly caused by deficiency of erythropoietin. As you know, erythropoietin is predominantly produced by the kidney. So any kidney disease can lead to reduction in erythropoietin production, leading to anemia. So the main cornerstone of managing anemia in CKD is treating with erythropoietin. But however, you need to recognize that there can be other causes of anemia in a CKD patient. So before starting erythropoietin, ESA stands for erythropoiesis stimulating agents. So erythropoietin is one of the erythropoiesis stimulating agents. There are other substances also, which I'm not going to go into detail. But erythropoietin is the prototype of erythropoiesis stimulating agent. So, so before starting ESAs, you have to exclude other causes for anemia apart from erythropoietin deficiency. So sometimes you can have nutritional deficiencies such as iron deficiency, folate, B12 deficiencies, and and there can be bleeding. So there are so many causes for anemia in CKD patients. So you need to exclude them before starting ESAs. And one of the important things about treating anemia in CKD patients is first checking for presence of whether the patient has iron deficiency. So you know what are the things that you have to do to check for iron deficiency. So you can use various tests such as serum ferritin, transferrin saturation, and so forth. Things like that. But in CKD, sometimes assessment of the iron status can be difficult. And that is because sometimes ferritin levels can be high because of inflammation, because they commonly have other inflammatory conditions. So therefore we have to use more than one parameter to actually assess the iron status. So classically, we consider somebody as having iron deficiency in CKD if that transferrin saturation is equal to or less than 30. Usually it's less than 20 in normal people, but in CKD people, we go up to 30. So even above 20, we consider them. If they are below 30, we consider them iron deficient. And serum ferritin up to 500, we consider them as having iron deficiency. So in other words, up to these levels, we have to consider replacing iron in these patients. So iron administration is recommended if the hemoglobin is less than 12 in females or less than 13 in males, and if they are associated with these parameters. And mostly the patients are treated with oral iron, but sometimes you might have to resort to intravenous iron, especially in these situations. If there's very severe iron deficiency, so that transfusion saturation is less than 12%. If the anemia is also severe, if it's less than 7 grams per deciliter hemoglobin, if there's ongoing chronic blood loss, so that you have to replenish the iron stores pretty rapidly. And if somebody is unable to tolerate oral iron, as you know, oral iron can be associated with a lot of gastric side effects. So sometimes it's difficult for them to tolerate the drug. So therefore, you have to use IV iron. And sometimes oral iron, they don't respond. So that is another indication to start IV iron. And also, if somebody is having anemia and is on dialysis, preferable to use IV iron because it's easy to administer. When they come for dialysis, you can give the IV iron. And also, they are more likely to lose blood during dialysis and various other procedures. So therefore, they are more likely to be needing a lot of iron. So that's why you consider IV iron in these patients. And so these are some of the preparations of iron that is available. So you can, the commonest one is oral ferrous sulfate, which has a strength of about 325 milligrams. And each tablet contains elemental iron of 65 milligrams. So if you use it 3 times a day, roughly you give about 200 milligrams of elemental iron per day. So in addition to that, there are other iron preparations. One is oral ferric citrate. So it's a new preparation, new in the sense, newer preparation. The advantage of ferric citrate over ferrous sulfate is that citrate, the ferric in the citrate tablet can be used as a phosphate binder. So we'll talk about phosphate binders as we go on. So it has two functions. One thing is to provide iron. The other function is to use function as a phosphate binder. In addition, there are several intravenous iron preparations. Iron sucrose, which is the commonest available IV preparation. And then you have ferric carboxyl maltase, which is a kind of mega dose that you use once a week, and it's not available in Sri Lanka. And so the problem with IV iron is that the patient has to come to a hospital or some place to get the injections. So they can't take it at home. So one advantage, as I have discussed, is when they're on dialysis, you can use the dialysis to give the iron. So when they come for dialysis, you can initially give them a loading dose, with each dialysis 100 milligrams of IV iron, followed by 100 milligrams every other week as a maintenance dose. So you don't have to remember the dosing regimes, but you need to just remember that these injections can be given during dialysis. And so that's about iron. So once you, either if the patient is not having iron deficiency or if the iron deficiency is corrected, then still if the patient continues to be anemic, then you have to consider using ESAs. So treating anemia in CKD with ESAs, there are two main goals. One thing is to treat the symptoms of anemia. So because you can have various symptoms of anemia. So fatigue, tiredness, exertional shortness of breath. So all these are symptoms indicating that the patient needs any erythropoiesis stimulating agents. The other objective of aim of using ESA is to avoid blood transfusions, because as you know, blood transfusions can be associated with sort of problems in patients with CKD, or as for that matter, any patient. But mainly in CKD, because especially if the patient is waiting for a kidney transplant, exposing to blood transfusions can lead to sensitization. And production of antibodies against HLA antigens, which can be a problem when you go for a kidney transplant. So therefore, those are the two main reasons why we try to minimize, why we treat anemia with erythropoiesis stimulating agents. So usually, ESAs are not started until the hemoglobin is less than 10. So that's the standard. So up to above 10, even if the patient is anemic, ideally, anemia is defined as less than 12 in females and less than 13 in males. But even if they are below that levels, if their hemoglobin is above 10, normally you don't start erythropoiesis stimulating agents. Only if it's less than 10, we generally start. But of course, if the patient is symptomatic, even above 10, we might sometimes start or consider it. And of course, we need to make sure that the patient's iron status is okay. And the other thing is erythropoietic stimulating agent is not totally harmless. So that's why we are very specific when it comes to starting ESAs, because sometimes people can develop strokes and worsen worsen the activity of malignancies when you are treated with ESAs. So that's why you have to be careful when you're starting these treatments. So there are various types of erythropoietin stimulating agents. So there are short-acting ones like epoetin alpha and beta, which usually is given 2 to 3 times per week. Usually they come as a 2,000 or 4,000 or 5,000 international units. You don't need to remember the doses, but you need to remember that some short-acting ones usually have to be given 2 or 3 times per week. And then there are long-acting ones like darbepoetin, which can be used once in 2 or 4 weeks. And some preparations like Mircera, usually it lasts for 1 month, so you can give monthly. So advantages of long-acting erythropoietin stimulating agents is that they can be used less frequently, so that so they don't have to come to hospitals frequently. So their compliance can be increased. And route of administration of the injection is usually subcutaneous, like an insulin injection. And usually that is preferred for people who are not on dialysis. And also it can be given intravenously. And this is preferred in patients who are on dialysis, because it can be given after completion of the dialysis with returning of the blood during dialysis. And so the target hemoglobin in CKD is from 10 to 11.5. So that is the range that you want to keep the patient in. If if the hemoglobin goes above 11.5 while on ESAs, you have to reduce the dose. And especially you should avoid them going above 13 because of the problems that I have already told you. And so these are the adverse effects of ESAs. So you can worsen your hypertension, so that your blood pressure control can get worse. So you have to make sure that you appropriately increase the antihypertensives to improve the blood pressure. And sometimes with the improvement in hemoglobin, their vascular access can develop thrombosis, fistula can get blocked. And then you can have a higher risk of developing cardiovascular events like myocardial infarctions or strokes. And also, as I told you, it is associated with increased malignancies. Right. So the next component is how we manage mineral bone disorder. Before that, are there any questions? Anything anybody wants to ask? Anything about anemia? Before we move on, you can just send some questions on the chat while we go on. Right. Okay. So you can just send questions as you wish. So we'll move on. Yeah, there are a few questions. What is the risk of HB if it exceeds more than 11.5 with ESA. So I have given the answer for that. The risk is that, they can develop access thrombosis, they can have strokes, myocardial infarctions, and sometimes they can have, um, problems like that. So that's why you want to make sure that it does not exceed 11.5. Yeah, so the same question, why don't we increase HB above 11.5? Then somebody's asking, can you please do this more slowly? Yeah, so because we have to finish a lot of material within by 3 o'clock, because we have to finish by 3 because we have another lecture. So that's why I'm going a bit fast. But of course, you can ask questions, and if you are not clear about something, you can ask me. Does treatment with ACE inhibitors aggravate anemia in CKD? It does, because the ACE inhibitors is one of the causes for anemia in CKD, but it's not the effect is not so big. So that's not a reason to avoid ACE inhibitors in CKD. What is the mechanism in using ACE inhibitors in protein? I've lost the. Can you all hear me? See the screen?
Yes, sir, we can hear you.
Sorry?
Yes, sir, we can hear you.
No. Can you see my screen?
Yes.
Right. Okay. Right. Okay. So let's move on to the next part of this talk, that is on CKD mineral bond disorder. So as I told you, another important components of mineral complications of CKDs is mineral bone disorder. So there are three main components in mineral bone disorder associated with CKD. I have taught you all these things in the nephrology module, so I'll just run through this. So one component is that you can have various laboratory abnormalities. You can have abnormalities in calcium. Usually calcium levels are low, phosphorus levels are high, and usually the parathyroid hormone levels are also elevated in this condition. So this is the biochemical abnormalities you get in CKD. So there is one component of mineral bond disorder. Then you can also have bone abnormalities. So you can have osteoporosis, osteomalacia, osteitis fibrosis cystica, and sometimes adynamic bone disease. So these are some of the changes you get in various problems you get in CKD. So we have already taught you all these things. So you can go back and read. Then the third component is ultimately what really matters is this extra calcium and phosphate. They end up in getting deposited in various soft tissues in the body, including a smooth muscle in the blood vessels. So that is how they are one of the reasons why they are at a higher risk of developing cardiovascular disease. So that is the third component of CKD MBD. So then now we try to see how this happens. So this is one of the famous slide. You would have been taught this during your basic sciences and later on the nephrology module, how these things happen during CKD. So initially when the GFR drops, there's a reduced clearance of serum phosphate, and there's accumulation of phosphate, and also there's another substance called FGF23 which is also getting accumulated, and these lead to reduction in um, 1 alpha hydroxy vitamin D level, and that in turn lead to reduced calcium level, ending up in secondary hyperparathyroidism. So there are so many pathways which are operating in CKD, ultimately giving rise to these biochemical abnormalities: high phosphate, low calcium, and uh, high levels of PTH. So one of the key aspects of managing mineral bond disorders, and one of the earliest changes to get is this high phosphate level. So important thing is to first ask the patients to reduce the dietary phosphate and also to administer phosphate binders. So we'll take one by one. So you need to know what are the sources of high phosphate. So it's mainly seen or found in dairy products, cheese, yogurt, ice cream. So any dairy product, you have high levels of phosphate. So you have to ask the patients to reduce to consume this less frequently. And also processed food also have high phosphate level, because phosphate is a component of most of the preservatives used in chemicals which are used to um, keep or preserve food for a longer periods. So therefore, processed foods are especially, bacon, ham, sausages, and things like that. They contain a lot of phosphate. So those are the things that you have to ask the patients to avoid. And most of the time, phosphate dietary restriction alone is not enough to control the phosphate level in the blood, and you will need phosphate binders. So phosphate binders, the mechanism of action is they bind to the calcium component of the phosphate binder, or the whatever, what happens is the binder gets attached to the phosphate which is in the diet, and then they prevent absorption into the blood. So there are two types of phosphate binders: calcium based and non-calcium based. Common one which is available is the calcium based phosphate binder. Calcium carbonate and is the commonest one, but you have calcium acetate. But the problem with calcium based phosphate binders is that, as I told you, in CKD, one of the main issues is deposition of calcium in the soft tissue, and especially in the blood vessels. So you would want to prevent people getting exposed to so much of calcium. So sometimes, especially if the patient's calcium levels are high in the blood, you cannot use calcium-based phosphate binders. So most of the time, you will have to end up using non-calcium-based phosphate binders, which don't contain any calcium. So there are a few types of non-calcium based phosphate binders. These are lanthanum carbonate, sevellum hydrochloride and carbonate, and also, as I told you in earlier slide, ferric citrate. So these are some of the non-calcium based phosphate binders. You need to know the names of these, because these are available in Sri Lanka at the moment. And it's increasingly being used for patients with CKD having high phosphate level. So so having spoken about phosphate level, another important component is high management of high parathyroid hormone level, because both high parathyroid hormone as well as low parathyroid hormone level can have problems. So therefore, the objective in CKD, in managing hyperparathyroidism, is to keep the parathyroid hormone level within 2 to 9 times upper limit of normal. So you don't want to make it normal. You can let it be high, but you need to make sure it doesn't go up above 9 times upper limit of normal, because you need high parathyroid level for the bone health, especially in CKD patients. But excessive PTH level can lead to fractures and also increased calcium and phosphate levels in the blood. And also there's a condition called calciphylaxis, where there is a deposition of calcium in the blood vessels, leading to superficial ulcers in the skin. So this can be very painful. So these are some of the problems with high parathyroid concentration, hormone concentration. So you need to control the PTH level. So what you do is you have to control the aggravators of high parathyroid hormone level. So as I told you in my previous slide, there are various mechanisms, feedback mechanisms by which PTH levels go up in patients with CKD. So one of the reasons is high phosphate level. So if you treat the hyperphosphatemia, then the PTH level goes down. And also low calcium level is another, and vitamin D level is another um, kind of stimulator or activator of PTH. So you have to optimize the serum calcium level and the vitamin D level, and you have to use activated forms of vitamin D, because the 1-alpha hydroxylation doesn't happen of vitamin D doesn't happen in CKD, as you know. So you have to use 1-alpha calcidiol or calcitriol preparations for these patients. And another type of vitamin D that we use is pericalcitol. So that's another preparation we use for patients with hyperparathyroidism in order to bring down the parathyroid hormone level. And sometimes these feedback loops don't work very well in patients with CKD. Sometimes the parathyroid gland starts to function autonomously. And this is called tertiary hyperparathyroidism. And in that situation, sometimes you have to use other medications such as calcimimetics. So the calcimimetic works is, as you know, the parathyroid gland has calcium sensors in the gland. So that is how it recognizes the calcium level in the blood and then reacts with the parathyroid hormone production. So what is done with calcimimetics is that these drugs go and act like calcium and block the receptors, or in other words, activate the calcium sensing receptors in the parathyroid. So the parathyroid thinks that there's a lot of calcium in the body and shuts down. So that is the action of calcimimetics. And but sometimes even those don't work, and you will have to end up doing parathyroid activity. So this is how you manage hyperparathyroidism. Right. So that we have, so basically those are the two main areas that we have to cover in the complications component. And anybody will have any questions like up to now with CKD? Any questions up to now? Because we are moving on to the next part, which is renal replacement therapy. So before that, we can answer a few questions. No questions. Okay, if you want, you can ask them later. Yeah, there are a few questions, you see. Yeah, if CKD has low calcium, why do we give non-calcium phosphate binders? Yeah, the problem in CKD is that the serum calcium level does not really reflect the total body calcium. So even though sometimes people can have low calcium, you should not try to replace the calcium. So that is a thing, because calcium can, as I told you, can go and deposit in these soft tissues. So therefore, even when sometimes when you have low calcium, it's better to use non-calcium based phosphate binders, because phosphate control is the priority in patients with CKD, because it is associated with high cardiovascular risk and mortality. So therefore, that is why. So most of the time, we if the calcium levels are low, we give calcium based phosphate binder because they are cheaper and freely available. But if the calcium levels are normal or high, especially, we should avoid calcium based phosphate binders. How often should the blood levels of PTH, calcium, phosphate should be measured? Yeah, so usually in clinical practice, it depends on the stage of the CKD. If you are having advanced CKD stages, 4, 5, like, you might have to do them monthly. But if you are in stage 3 or early stage 4, then we can do it every 3 months. So, and PTH level estimations are quite costly, so we don't frequently do that in our setup. Why don't bring PTH level to normal? I didn't hear properly. Yeah. So, so as I told you, PTH is parathyroid hormone is needed for maintaining good bone health. So, as you know, in CKD, the bone mineral state, because there are a lot of abnormalities in the calcium, phosphate, and all that. It's important that it's not a normal situation. So you need higher levels of parathyroid hormone to in order to keep this bone health optimal. So that is why in CKD you need a higher level of PTH level. So therefore you need to keep it at a higher range. And if you try to suppress this too much, then what happens is the bone goes into a condition called adynamic bone disease. So adynamic bone disease is associated with fractures. So that is why you need to make sure that PTH levels are maintained at a certain level. If a patient presents for the first time with a low GFR, how can we identify whether the person has CKD? I think now this is not the time to discuss this question, because this is a clinical question. This is about diagnosis of CKD. So I think we will discuss this at a different time, at a different time in your curriculum, because this lecture is intended to talk about therapeutics, treatment. So I'm not going to answer that question. The next question is the low calcium due only to reduced 1,2,5 dihydroxy? Yeah, no, low calcium can be due to so many reasons. So I think that's why you need to read the mechanism of bone mineral disorder in CKD. So you have to go and read. It is due to reduced vitamin D activation, due to high phosphate level, and various other mechanisms which is operating in CKD. Next question is why we don't maintain species in normal range? So that I have given the answer to that question. So okay, fine. So we'll move on to the next part, which is on. So I have only tried to discuss the two main complications. As I told you, there are so many other complications in CKD, but I'm not going to touch, because the treatment is mainly focusing on management of anemia and mineral bone disorder. So you need to know a bit more about them. So that's why I've tried to cover those two areas. You can read about the other areas. They are not really much relevant to therapeutics. Right. So having done all these things, finally, most of them still end up in end-stage kidney disease. So that means their kidney function progressively go down, and eventually they will need renal replacement therapy. So we need to know what renal replacement therapy is. So there are several modalities of renal replacement therapy. So in other words, renal replacement means you are replacing the kidney, either physically by renal transplantation or functionally by means of either hemodialysis or peritoneal dialysis. So when do you need a renal replacement therapy in CKD? As I told you, it is needed when the patient ends up with end-stage kidney disease. End-stage kidney disease means the kidney function has dropped off to a level that it no longer can maintain the normal physiological mechanisms or homeostatic mechanisms of the body. So in other words, the patient is getting various abnormal substances getting collected in the blood, and excessive, the body is unable to excrete extra fluid. So the patient needs some form of assistance in order to maintain life. So usually there are several clear-cut indications when we consider renal replacement therapy in patients with CKD. These are when the patients have hyperkalemia, fluid overload or pulmonary edema, if there is severe metabolic acidosis, if there is pericarditis, if there is encephalopathy, or if the patient continues to have persistent uremic symptoms, which are nausea, vomiting, loss of appetite, loss of weight, or pruritus. So these are some of the indications that we consider renal replacement therapy in patients with CKD. So this slide gives you various functions of the kidney, and what you need to understand is the renal replacement therapy or dialysis, especially only replaces two components of these kidney functions. This is salt. So the kidney is involved with salt and water and acid-base balance. So that component is, when it's deranged, that component is treated with dialysis. The next important thing is if there is, and also it helps to remove nitrogen end products like urea, creatinine, uric acid, and those substances. So those that also is helped by dialysis. But the endocrine functions like production of red cells and bone health, all these things which the kidney does which has a big role, they are not replaced by doing dialysis unless you do a kidney transplant. So that is one important thing you need to keep in mind. So moving on to dialysis, there are two main objectives of dialysis. As I told you in the previous slide, it is mainly used to remove nitrogenous waste products which are collected in the blood, so which is called solute removal, and also removal of extra water, salt and water, which is also collected in the body because the kidneys are unable to excrete this fluid. So this is called fluid removal. So solute removal and fluid removal are the main aims of doing dialysis. So solute removal, there are different mechanisms how dialysis helps to remove the solutes. So there are different ways: diffusion, convection, and adsorption. So diffusion means which is what mainly we use in the dialysis is diffusion. So it's a movement of substance from an area of high concentration to a low concentration across a semi-permeable membrane. So this is what is the semi-permeable membrane. So you have so basically I will show you how the dialysis work. I will show you how the dialyzer how it what's the structure of a dialyzer. But before that, you need to know the blood and dialysate are separated by a membrane, a semi-permeable membrane in a dialyzer. And so what happens is across the membrane, the solutes can go either way based on their level in the circulation and the dialysate. So basically the dialysate will not have creatinine and urea, so they are high in the blood. So therefore across the membrane, along the concentration gradient, the creatinine and urea will reach the dialysate. At the same time, if you want to replace some other stuff like calcium, as you might want to replace the calcium in the patient. So therefore you can have a higher calcium in the dialysate, so that will be transferred across the membrane. So this is the process which happens in dialysis. Other processes, convection and adsorption, does not really operate much in the dialysis. They are mainly used for dialysis in acute kidney injury, but so mainly the diffusion is the one which is used in dialysis in CKD. Then in addition, apart from solute removal, you have fluid removal. So fluid removal is done using two mechanisms. One thing is using osmosis. So osmosis is the movement of water across a semi-permeable membrane from an area of lower osmolality to higher osmolality. So you know that when you have higher osmolality, that area attracts water. So that is so you make the dialysate more hyperosmolar by putting substances like glucose or some other substance, and therefore you can attract the water from the blood. The other mechanism is hydrostatic pressure gradient. So if you want to get water uh, from a from blood, you basically apply negative pressure to the dialysate so that the water can be sucked out from the blood. So these are the two mechanisms how you remove fluid. So as you see that there are, so in the semi-permeable membrane, there are pores through which the water molecules can uh, come out into the dialysate. So that's called the filtrate. So this is how the osmosis works. So this is blood, this is the dialysate. So you have higher glucose molecules in the dialysate so that you can get the water, attract the water into the dialysate compartment. So, so in hemodialysis, you have several components in the process. One thing you need to have a dialyzer, which is called an artificial kidney. I will show you what it is. It consists of a semi-permeable membrane, so which could be either cellulose, substitute cellulose, or synthetic non-cellulose membrane. So these are early days we use cellulose membranes, but now we are using synthetic non-cellulose membranes. Then you need to have a dialysis solution, which should contain a solution which is free of these toxic substances. And if you want to add some substance to the blood, you can add it to the dialysis solution. Then there you need to be a tubing where the blood and the dialysis solution is carried, and also there needs to be a machine where these things are operated. So this is a dialysis, how dialysis is happening. So this is a machine, and this is the artificial kidney, which is called the dialyzer, and these are the tubings. I'm sure you'd have seen dialyzers during your nephrology appointment. So this is the schematic representation of how the dialysis works. So there are two lines. One is called the arterial line. So arterial line, one is called the venous line. So this is called the arterial line is called the outflow line. So outflow line takes the blood from the patient and sends across the blood pump. So it generates the flow of the blood, and it runs through to the dialyzer, and through the dialyzer, this is from where the dialysis solution goes the other way, using a counter current mechanism. I'll explain that to you later. So the blood, when the blood goes through the dialyzer, it gets cleaned, and all the extra fluid is also removed, and then the clean blood will go through these filters and back to the patient. So this is the inflow line. So this is the basic structure of a filter, and this is a filter. So the blood goes from the top to bottom, whereas the dialysis goes from bottom to top. So there's a counter current mechanism operating in a dialyzer, and if you get a cross section, you can see these tiny tubes within the dialyzer. These are these are cylindrical tubes which carries blood, and outside these tubes you have the dialysate. So the dialysate and the blood don't come into contact with each other. They are separated from by a semi-permeable membrane. And why there should be a counter current mechanism is to facilitate the transfer of fluid and solute. So if you see now, this is the blood, how the blood goes from top to bottom. So, and the dialysate goes from bottom to top. So the blood will have lot of high concentrates of blood, urea, creatinine, potassium, as it enters to the dialyzer. And at this point, and the dialysate solution usually has the lowest concentrations of these substances. It's quite clean when it enters the dialysis in the dialyzer. So the concentration of the solutes are highest at the top. So by what happens is when the dialysis solution travels from bottom to top, it gets continuously saturated with the toxic substances coming from the blood. So the concentrations of these toxic substances are the lowest at the bottom and highest at the top. Whereas from in blood, the concentration is highest at the top and lowest at the bottom. So at every time, every point along the way, there is a concentration gradient which is maintained, allowing the solutes to be transferred from blood to the dialysate. So this is the whole idea of using this counter current mechanism in the dialysis. So standard hemodialysis is performed 3 times per week. So that is everywhere in the world. It is in-center hemodialysis where the patients come to a dialysis center and get connected to a machine. Usually that is done 3 times a week. Each session lasts for 3 to 6 hours, but usually it's 4 hours. And especially in other countries, because this is a labor intensive process and the patients have to travel to the center, they have home hemodialysis or nocturnal daily dialysis, where the dialysis unit is created at their own homes, and they just have to connect themselves to the machine during sleep. So every day they go on the machine during the night and take off the machine during in the morning. So they are not compromised by the dialysis, but we don't have that facility in Sri Lanka. So in order to maintain good hemodialysis, you need to have good access to patient circulation, because blood has to be taken out and had to go through the machine and in order to do the dialysis. And also the patient has to have a good hemodynamic status, in other words, good blood pressure, and so that the patient can tolerate this procedure. So there are different types of vascular access. Commonly what we use is arteriovenous fistula, or else we can use a venous catheter. So this is a fistula which you would have observed during clinical appointments, which is created, which is a connection of artery and a vein, and this is the vein which has become arterialized once it's connected to the artery, and then you can use this to cannulate and take blood. And this is a catheter. This is sometimes not a catheter. So this is arterial and venous lines that I described. So this is a fistula. So one line will carry the blood into the machine, and one line will carry the blood back to the patient. So this is how blood is taken for dialysis using a fistula. And this is a line. So this is a permanent catheter where there are 2 lines are being inserted through a subcutaneous tunnel, and they are connected to the internal jugular vein. So one will take the blood to the dialyzer, this red one, and the blue one will carry the blood back to the patient. So dialysis is also not without complications. So you need to have some idea, because it's very common now these days in our practice, people on dialysis. So there are several common complications, such as blood pressures can drop, especially when you are using high volume removal, cramps, nausea, vomiting. Sometimes you can have reactions to dialysis membranes, and you can have infections, especially when you use venous catheters. And sometimes these fistula can undergo thrombosis or stenosis. So these are some of the complications. And then, so that is about hemodialysis. Then about peritoneal dialysis, it is not very much used in Sri Lanka, but it is something that you need to know, have some idea. So compared to hemodialysis, peritoneal dialysis doesn't use a machine as such. It uses the natural peritoneal membrane as a semi-permeable membrane, and what you do is you infuse the dialysate into the peritoneal cavity, and the peritoneal membrane is used as a semi-permeable membrane between the blood vessels and the dialysate. And across the semi-permeable membrane, you can extract the high concentrates of blood urea and creatinine and other solutes into the peritoneal fluid, and then you can remove the peritoneal fluid. So what happens is you infuse the fluid into the peritoneal cavity, keep it for about 4 hours or 6 hours or 8 hours, depending on the various cycles that you use, and then you remove. So then with that fluid, you remove, solutes which has diffused across the semipermeable membrane. And also you can use glucose in the solution so that you can extract or ultrafilter extra water also back to the drainage bag. So what happens is you do about 3 or 4 cycles per day in each patient. And what the patients do is they can do it at home without coming to a dialysis center. So this is a home-based treatment. And I will not waste a lot of time here. So there are two types. One is this continuous ambulatory peritoneal dialysis, which I have showed you. The other one is automated peritoneal dialysis, where they use a machine. So this is the continuous ambulatory peritoneal dialysis, where the patient connects the bag into the peritoneal cavity, and then they disconnect the bag, and then wait for about 4 to 6 hours, then come back and then connect to the drainage bag and drain the fluid. So they do it manually. Then you have the machine. You can use a machine to do the same thing. So the bags are connected to the patient. Once it's connected, automatically the machine runs the dialysis, like in a hemodialysis machine. So there are different types of dialysis which is available through the peritoneal cavity. Yeah, so I think I have discussed most of these. So these are somehow they do the exchanges. And this is about acute automated peritoneal dialysis. And this is a PD catheter. So basically you have to get this, usually is inserted by a surgeon, and the patients can use these connectors to connect to the peritoneal dialysis solution bags. And again, peritoneal dialysis, the advantage is that they can do it at home, no need to go to the hospital. But at the same time, there can be complications. These include peritonitis, because you're having a device in the tube in the abdominal cavity, so you can have infection introduced into the abdominal cavity, and then you can have malnutrition because protein, especially albumin, gets lost with the dialysate in using the peritoneal membrane. And sometimes you can have fluid leaks when you have about 1 or 2 liters of fluid in the peritoneal cavity. And also you can end up having hernias because of the increased abdominal pressure. Yeah, so and the final mode of renal replacement therapy is, of course, renal transplantation, and that is the best form of renal replacement therapy, because in addition to solute removal and fluid removal, you can also replace the other functions of the kidney by transplanting a kidney. So, and if you compare the survival rates on hemodialysis versus peritoneal dialysis, hemodialysis versus transplantation, it's clearly transplantation will give you a survival advantage over hemodialysis. At the same time, it will give you a better quality of life because you don't have to go on dialysis. So, what you do is you transplant somebody else's kidney to a patient at a different location. These are the 2 native kidneys which are obviously having CKD, and then you have the normal functioning donor kidney. You transplant it to the groin area of the patient. So there are different types of transplantations. You have live donor transplants, where a person is donating, a living person will donate a kidney to a patient. And the other method is a cadaveric transplant, where a patient, brain dead or a non-heart beating donor's kidneys can be used to transplant into a 2 kidney patients. Then in relation to therapeutics of transplantation, you need to know some of the drugs that the patients are using. These are the immunosuppression medications, because without because the natural immunity will try to reject the foreign organ from the body, so you need to suppress the immunity. So there are different types of immunosuppression. Commonly you use prednisolone, azathioprine, mycophenolate, cyclosporine, tacrolimus, sirolimus, and various types of other injections, intravenous medications. So you don't need to know a lot about these drugs, but you need to know a few names, and also few complications following kidney transplants, infections, high risk of malignancy, because their immune system is important to uh, you know surveillance for the surveillance against malignancies, and also drug side effects. All these things you need to have a bit of idea. I will share these slides with you, so you can go through them. But most important thing is you need to remember is that this is the best mode of renal replacement therapy, and some of the side effects of these medications also you need to keep in mind. And finally, Sri Lankan situation. So we have limited availability of dialysis for these patients in Sri Lanka, because we don't have many machines, or we don't have a lot of dialysis centers, and we also don't have staff to provide hemodialysis. So mostly this chronic hemodialysis is not available. Mostly we do dialysis to provide a bridge to transplantation. Until they go on kidney transplantation, we provide them dialysis in the state sector, but obviously private sector will have dialysis, but then the patients have to pay. Peritoneal dialysis is underutilized. R is missing here. So underutilized modality. And kidney transplantation predominantly is a live donor transplant, that program we have. Cadaveric transplant program is not well structured or organized in this country, which needs to improve. Okay, so any other questions? We have about 10 minutes. So let's see. Does transplant cause osteoporosis? Or is it only due to disease itself? Yes, now CKD per se also can give rise to um, give rise to osteoporosis. As I told you, it can cause renal bone disorder. At the same time, uh, transplant also can cause osteoporosis because of a different reason, because that is caused by prednisolone, because steroids one of the causes for osteoporosis. So that is the answer for that. Isn't venous catheters are used only until AV fistula is ready for dialysis? Yes and no, because you don't have to go through a phase of venous catheters before needing before using the fistula. But what we normally do is we don't wait until the patient uh, gets the need for starting dialysis. What we do is we anticipate, because we follow up the patients. We know that in about 3-4 months, a patient is going to need dialysis. So we prepare the fistula in advance. So by the time the patient needs the dialysis, the fistula is ready. But of course, majority of the patients, they don't get these fistula done in time. So some of them will need to be put on catheters for initial dialysis until they get the fistula done. What are the common malignancies following renal replacement? Yeah, renal replacement in the sense what I think is meant is transplantation. So the common malignancies that you get are lymphomas and also skin malignancies. You can get basal cell carcinomas, squamous cell carcinomas. So those types of cancers you can get. But so those are the common ones. But there could be other ones also. What is the amount of protein a patient can take? Yeah, so I understand. I assume that this is in relation to CKD. So it's a very good question, because protein, as I told you, is associated with increased glomerular filtration rate, and that will give rise to filtration injury to the glomeruli and lead to acceleration of chronic kidney disease. But at the same time, by restricting protein, also there are risks. You can end up, the patients can end up with malnutrition. So that can also lead to protein catabolism and adverse health outcomes the patient. So I think for our patients, since we are an Asian country, anyway our patients are not used to very high protein intake. So I think what we should encourage them is to use a normal protein diet. But I think what a normal protein diet in our setup is usually about zero point 0.6 to zero point 0.8 grams per kilogram body weight. So that's roughly the amount that you ask the patient to take. And but if they are, once they are on dialysis, because it's a very strenuous procedure and it takes a huge strain on the body, patient needs to be on high protein diet when they are on dialysis. So that's another thing you need to know. Can we use renal replacement for patients before the end stage indications are there? No, because again, renal replacement, when you use as a broad kind of a term, it's difficult to answer this question. So if I divide the renal replacement into two categories, dialysis and renal transplantation, obviously you don't want to put somebody on dialysis before the indications. They have to have those one of those indications which I described earlier to put them on dialysis. But for transplant, it's different, because if you know that somebody is going to end up with end stage kidney disease at some point, sometimes before they develop the symptoms, we put them on, we give them get them a kidney and do a transplant, so that they will never reach that stage where they develop symptoms. So that is called a preemptive kidney transplant. So that can be done. What's the role of ACE inhibitor in diabetic nephropathy, which I'm not going to answer again. You have to read and find out, because this is one thing that we have been teaching you all from the time you started the medical school, and also in the nephrology module. So you have to know. I'm not going to talk to you much about that. Is there anything given for infection prophylaxis or bleeding tendency? I don't know where, in which situation. It's not very clear what the question is. Basically, after transplantation, yes, because there is reduced immunity and the patients at a risk of opportunistic infections, we generally give prophylactic drugs, especially co-trimethoprim is given to prevent PCP pneumonia. And so that is the main drug that we use for infection prophylaxis. And also for 3 to 6 months, we use valganciclovir to prevent CMV infection. So these are the two common prophylactic drugs we use. Bleeding tendency, I don't know what you mean by bleeding tendency. It's not increased in post-kidney transplant patients. I think that is it. If there are any questions, I know that you have got another lecture at 3 o'clock. So we'll finish it here. And we'll meet again on Friday for another therapeutic lecture on AKI. Okay, thank you very much.